the organizers to bring me here. It's a big pleasure for me and the first time to be here. It's really great to be here. So I was asked here to give my first talk about, to give maybe an idea of the current status of femoral interventions. This here is my, does it run? Can you switch, continue, or? Yeah, my disclosure slide. So, of course, if you want to question this, to answer this question, you have to follow a lot of questions. Like, for example, you have to start with the question: where are the indications, clinical status, what is the lesion morphology which you want to treat by endovascular, techniques, technologies to pass the lesions, techniques to do the angioplasty itself, and of course also the post-interventional treatment and surveillance is important for our patients when we do an endovascular treatment here in this arterial level. In this talk, I will concentrate on the techniques, maybe technologies to pass occlusions or stenosis, mainly occlusions of the SFA, and also to answer some questions about what kind of angioplasty technology and technique we should maybe use. So to start with, this is, an ongoing question. If we have a total occlusion of the SFA, should we try it intraluminally? Shall we go through subintimally? What is actually the best way to do it in terms of success and also in terms of patency later on? And so far, we do not have any randomized trials to compare these two different techniques to pass occlusions. And we're actually quite left alone with this question. However, there was a publication here now last year, which I found very interesting and very helpful in this regard. It is coming from Japan, where they tried to compare a group of SFA occlusions, long SFA occlusions, in an intraluminal way compared to a subintimal way. And it was retrospective, of course, this is a weakness, and however multi-center, and this was done by cardiologists. And you know very well that Japanese cardiology, if they try to go through a total occlusion intraluminally, they really try it for hours with many wires. So I think you can really believe this group of 651 patients where they tried intraluminal with 0.14 wires compared to a subintimal way with an 0.35-inch wire. But what you can see here is that the results were pretty the same. Success rate the same, procedural complications also the same. Procedural time, however, was longer when you try to do this in an intraluminal way. And the endpoint was here, the 3-year primary patency after stenting, however, was also completely the same. And there was a switch over for 25% from the intraluminal group to the subintimal because they failed to do this intraluminal. So they concluded that actually you can right away take an 0.35-inch wire and do the subintimal way, and you will reach your goal much faster. What's not shown here on this slide is that actually in a subgroup they tried to figure out, are they really intraluminally when they try to, or are they subintimally when they try to do this by IVUS or ultrasound from outside? And what they found that not always when they tried to do intraluminally, and they thought they would be intraluminally, they were by ultrasound, and also not always when they thought they were subintimal, they were subintimal, sometimes they were also intraluminal